Is that good?
Yes.
All right, so from the beginning. Good. Right. Hi, everyone. My name is Nongceba Quarantine. I am a radiologist at Nelson Mandela Children's Hospital. And I'm presenting with Ronnie Munareng, who's a chief radiographer in the cath lab. So we're going to be presenting on total and partial anomalous pulmonary venous return. And we have a case that we're going to present as one of the cases we've seen early in the year. So what is total anomalous pulmonary venous return compared to, as opposed to the partial anomalous venous return? With TAPVR, you have cyanosis. It's a cyanotic congenital anomaly with abnormal drainage anatomy of the entire pulmonary venous drainage. So if you look at the diagram here, you have the SVC, the IVC, coronary sinus draining into the right atrium. Can you see my arrow?
Move it again.
Yes.
Yes, we can.
On the deck. Okay, perfect. So you have those, you have venous drainage into the right atrium, then through the tricuspid valve into the right ventricle, into the pulmonary trunk, and then the lungs via the pulmonary arteries. And then the venous return is meant to come back via the pulmonary veins, which then drain, instead of them draining into the left atrium, there's anomalous return whereby it drains back to the right atrium. So with the total anomalous pulmonary venous return, all 4 pulmonary veins fail to form a direct connection with the left atrium. So there's nothing that goes to the left atrium. Instead, you have oxygenated blood returning to the right atrium. And then for survival, you would need an ASD so that there is blood transferred from the right to the left atrium. As opposed to a partial anomalous pulmonary venous return, where some, but not all of the pulmonary veins drain into the systemic circulation. Into the right atrium. So what happens now is that these patients you tend to see them later in life because they do have some sort of pulmonary venous return into the left atrium. So in terms of prevalence, it forms about 1% of all congenital heart disease, with a male predominance of 4:1 in the infracardiac type, which is the total anomalous that we'll go into just now. So firstly, I wanted to go into the embryology so that we get to understand the formation of the pulmonary veins and what happens when there is failure at any point in this formation. So in early embryogenesis, which is around 27 to 29 days, the lung buds are surrounded by the splanchnic plexus, which is this plexus over here, which is the foregut vascular plexus. And there is one commonly accepted theory that suggests that blood returning from the lung buds initially drains into the splanchnic plexus, which communicates with paired cardinal veins as well as the umbilical vitelline veins. So you've got this right cardinal vein and the left cardinal vein and the umbilical vitelline vein. So, and then as time goes by at around 32 to 33 days, you have a common pulmonary vein, which is arising as an outpouching from the dorsal wall of the left atrium. So this is where eventually you're going to have your 4 pulmonary veins arising from. So with time, the common pulmonary vein communicates with a portion of the splanchnic plexus, which is in this diagram here where you see communication. But over time, around 38 to 40 days, then you get involution of the connections with the cardinals, the left and right, and with the umbilical vitelline veins. So ultimately giving rise to, so the common pulmonary vein, which is at the dorsal wall, of the left atrium, then eventually forms the separate 4 pulmonary veins. So if you look at the diagram here, the right cardinal venous system eventually develops into the SVC. The left usually disappears, but you do know that in like about 1% of the population, you do have a left SVC, whereby you have a double SVC. And then the umbilicovitelline vein, which is this one there, develops into the inferior vena cava, the portal venous system, and ductus venosus. So if you have at any point of the development that certain processes fail to occur, then you get your abnormal pulmonary venous return. So we're going to start with the total one, where there's 4 types. There's a supracardiac, which is a type 1. So supracardiac, essentially, you have the pulmonary veins. They form a vertical vein, which goes into the innominate vein on the left, and then you get the drainage into SVC and then into the right atrium. So that blood is oxygenated. And then now for survival, like I said, you have to have an ASD. So this blood would then be going into the LA. And then type 2 is at the cardiac level. So that's supracardiac. And at the cardiac level, so those veins converge and then actually drain into the right atrium itself or into the coronary sinus. And then infracardiac, they converge to form a vein that descends and into the, like below the diaphragm, into either the IVC, hepatic vein, portal vein, ductus venosus, or the IVC itself. So, and then you have the mixed type, which is a combination. It could be a combination of any of the 3 types. So the most common one is the supracardiac. So pathophysiology, therefore, you have mixing of oxygenated and deoxygenated blood in the right atrium, but an ASD is necessary for survival. So oxygenated blood returning to the right atrium is directed to the left, then into the systemic circulation. So the oxygen saturation is similar in the pulmonary and systemic circulation. And then you find that because of that, then you have a sort of hypoplasia or a relatively smaller left heart compared to the right. Clinically, presentation will depend on whether it is obstructive or if there's venous obstruction or not. So you can imagine if you are going infracardiac, you are likely to obstruct at the level of the diaphragm. So the supracardiac and cardiac type usually don't present with obstruction. So they can be asymptomatic at birth, but develop symptoms as a result of pulmonary overcirculation in the first few days of life. And then cyanosis can also be variable, whereby it can actually be mild. They present with dyspnea, failure to thrive, feeding difficulties, and tend to have growth restriction. And then they can present in cardiac failure as well, where they have pulmonary congestion, tachycardia, tachypnea, hepatomegaly on clinical exam. So, so that's part of so that was clinical presentation. And the clinical examination on auscultation, they have a fixed and widely split S2. They may have a P2 that is accentuated. They have a hyperactive right ventricular impulse, and they have an ejection systolic murmur. And the mid-diastolic rumble can at times be heard in the lower left sternal border, which is because of relative tricuspid stenosis. And then on ECG, on electrocardiography, you may have right atrial dilatation or right ventricular hypertrophy, and occasionally, right ventricular hypertrophy, and occasionally right atrial hypertrophy. So now with the infracardiac type, whereby it's crossing the diaphragm to appear to drain into the IVC or hepatic veins, obstruction is at the level of the diaphragm, and then they can present with quite severe respiratory distress and cyanosis at birth. So they're usually hypoxic, they're hypotensive and tachypnic. And in terms of auscultation, they may have loud single S2 and an S2 gallop, and pulmonary crackles will be because of the pulmonary congestion, and they don't usually have a murmur. And then ECG as well will also, in line with the previous one, where there's a right ventricular hypertrophy or right atrial hypertrophy. So diagnostic tools, we've already discussed the ECG, and then chest X-ray. The typical snowman sign is only seen in a supracardiac TAPVR, because if you look at the diagram and you look at the X-ray, you have your normal, your SVC, which ends up becoming dilated because there's increased volume from the vertical vein. So if you look at this vertical vein that goes superiorly, then you have a radiodensity in this region that eventually forms the head of the snowman, and then the rest of the heart will form the body of the snowman. So that's the typical snowman sign in a TAPVR. And then other features on X-ray would be a cardiomegaly and eventually cardiac failure. But chest X-ray is not diagnostic. A two-dimensional echo is usually diagnostic, where you'll see right ventricular overload, dilated vertical veins, the vein that we've discussed, and then innominate vein and SVC. And then there won't be any direct communication of any of these pulmonary veins with the left atrium. And there'll be a dilated coronary sinus protruding into LA. And then you may get the left heart being hypoplastic. And then cardiac cath is not usually necessary because an echo is usually diagnostic. However, they may want to dilate, or do an atrial septostomy, a balloon atrial septostomy, where they enlarge the interatrial communication as a temporary measure to improve right to left shunting while preparing for surgery or definitive management. And then with regard to cross-sectional imaging, CT, obviously CT, the disadvantage of ionizing radiation and MRI not having, so obviously it depends on your center. So with us, we do quite a bit of CT angiogram for cardiac cases. So it's not always necessary, but in complex cases, you may want to, do a cardiac CT. So what it does for you, the CT angiogram, you get preoperative determination of the exact anatomy and drainage, and then your 3D reconstruction as well provides the surgeon with a surgical roadmap. And then you can compare the pre and post-operative pulmonary vein measurements, and then post-op as well. So, if you're worried about post-operative stenosis. And then in terms of management, you want to use prostaglandins to improve systemic perfusion if there's pulmonary hypertension, diuretics or any anticongestive measures for non-obstructive type, and oxygen. So patients tend to be intubated, post-surgery. This particular patient that we've had to do ECMO on, which is a pulmonary or cardiopulmonary bypass technique in those with severe cardiac or respiratory failure, which is refractory to conventional ventilatory support and medical intervention. So in this case, this patient was on a peripheral VA ECMO, whereby you have your arterial line and your venous line going into the superior vena cava. And then in terms of surgical management, it's usually it's indicated for all patients. So patients without PV obstruction, pulmonary vein obstruction, are operated on as soon as possible. So post-surgical mortality rate is about 20%. And in those with obstruction, so I think this is the other way around, not what I'm saying. So I think it's the other way around, whereby if there's obstruction, it has to be as soon as possible. And if it's without the obstruction, then it's later on 4 to 12 months. And then, so the definitive management, the point is that you need to return the pulmonary drainage into the left atrium. So for the supracardiac, they do a side-to-side anastomosis between the pulmonary veins and the left atrium, and then they ligate the vertical vein, and then you close the ASD. And if it's a TAPVR, then there's another type of surgery where they connect it to the right atrium. So whereby the atrial septum is excised, then they have a patch such that the pulmonary venous return is diverted to the left atrium. And then, or you can have unroofing of the coronary sinus, where the communication, the coronary sinus for communication between the coronary sinus and the LA is created. And then you have a patch that closes the septum. And infracardiac, the large vertical anastomosis is made between the common pulmonary vein and the left atrium, and then the common pulmonary vein is ligated above the diaphragm. So now, partial anomalous pulmonary venous return is about 0.4 to 0.7% of congenital abnormalities, and where you have one or more, but not all of the veins draining into, whether it's SVC, IVC, coronary sinus, or innominate vein. So the right side apparently is more involved than the left. And this anomalous drainage results in left to right shunt, as in an ASD, whereby the hemodynamics are similar to an ASD. And the magnitude then of the pulmonary blood flow is determined by the size of the anomalous vessel and the presence or absence of an ASD. So hence some patients can present quite later in life as an incidental finding while being imaged for something else. So PAPVR, it's got some associations. There's heterotaxy syndrome, then there's Symmeter Syndrome. So the case that we've had is associated with a Symmeter Syndrome, which usually involves the right lung. So basically what happens is that you have that partial anomalous drainage with a small ipsilateral hemithorax where there's hypoplasia of that ipsilateral lung, and at times even the pulmonary artery can be hypoplastic, and then they tend to have blood supply from into that lung from another vessel like the aorta or descending aorta. They tend to have dextrocardia or dextroposition because of the hypoplastic lung. And then you get ipsilateral systemic collaterals from the aorta or its branches, which I've already mentioned. And then another association which this patient we thought to have in the from our CT is an extralobar sequestration, where they get congenital malformation of a portion of the lung that has no communication with the normal bronchial tree, and then usually has an aberrant arterial supply from the aorta or its branches. And then clinical examination and diagnostic tools, they're usually asymptomatic, and if undetected, may result in cyanosis or exertional dyspnea in later life, say the second or third decade. And we've got one of the patients that we saw just recently, which I'll show you the images just now. So on auscultation, they tend to have a split and fixed S2 if it's associated with an ASD. And then it can be normal if there is an intact septum. And then ECG can be normal, or you can have right ventricular hypertrophy, or they can present with a right bundle branch block. So chest X-ray, you may have an enlarged LV and an RV. You may have the Symmeter sign, which is essentially that abnormal vessel, which is connecting to the right atrium, may appear as a Symmeter. And then you may have your increased pulmonary vascular markings. If they do end up in cardiac failure, then you can get features of congestive cardiac failure on the radiograph. Echo can be less reliable in these patients because they do tend to have at least 2 or 3 other vessels that drain normally. So you may not even visualize the abnormal vessel that's draining into the right atrium. So cross-sectional imaging, important. These are the patients where you tend to now find it while you are doing other imaging for whatever other reason. So we had a patient earlier this year who on echo was presented by the cardiologist, Dr. Mamaila, and then she said on echo she's suspicious of a vessel. There's a vessel that looks like it's draining into the IVC or into the right atrium. So I'm just going to play that whereby, so this is liver, and that is heart, and here's the diaphragm. So now you have this vessel, and you can see that this vessel is coming up normally, draining into the just the infradiaphragmatic aspect of the IVC, and then going into the right atrium and then the right ventricle. So same here, just to visualize it better. So you're having this anomalous vessel that's draining into that distal IVC, into the right atrium. So then we did a CT angio, and then the CT angio, this is just a recon of it. And as you can see here, you can see this is right, that's the left side. And then here's this consolidated lung, which has abnormal vessels. And this vessel is going down under the diaphragm into the IVC, then only then draining into the right atrium. Same patient, you can see the dextral position because of the hypoplastic lung. So now the heart now is filling up, moves across and fills up the right hemithorax. This lesion only involved the right-hand side. As you can see here, this is your left atrium, and then on the left, you do have your pulmonary veins draining in there, whereas on the opposite side, you're not having a pulmonary vein. Hence, you're having the anomalous drainage from that side. Then, like I said, they tend to have hypoplastic pulmonary arteries as well. So here's the pulmonary trunk with a normal size left pulmonary artery of 5 millimeters, and then that one of 1 millimeter. And in this case, because of the very hypoplastic right pulmonary artery, this patient had arterial supply actually from the descending aorta. So, sorry. So this is a descending aorta, and then now you have a vessel that's, and then it goes across, and then it supplies up above the diaphragm, and then supplies this whole right lower lobe. So the right lower lobe, when we compared it to the opposite side, we were concerned that this could also be an extralobar sequestration. So in this patient, we have those associations where we've got PAPVR, you've got PAPVR, and then you've got sequestration, and you've got the Symmeter vessel. This one was the child I was saying that presented later in life, or I don't remember what they were presenting for. Then when we looked at this is the left atrium, and here's the left pulmonary vein draining into there. And then on the right, you scrolled all the way down, there's no venous drainage. So the venous drainage from the lower lobe was going directly into the right atrium, and then there was a superior vessel as well. This is a superior vessel that's draining directly into the right atrium. So management of these patients, usually surgical intervention at 2 to 5 years of age. And then it also depended on the site of the anomalous drainage. And with regard to future issues, obviously they will need to follow up with the cardiology team depending on their status. So we usually follow them up post-op. We see them because they usually are in ICU. So we see them for a couple of weeks, and then eventually over months. But they usually followed up quite long-term. And then imaging as well is very important for post-surgery, because complications, they can get obstruction of those surgical anastomoses. So then they tend to get followed up with imaging as well. And we try to not do too much CT imaging because of the ionizing radiation. So we've looked up, there were some articles that we found describing what to expect after repair of your total anomalous pulmonary venous return. This one was quite interesting. It was in 193 patients, and the conclusion was that survival in the third decade without reoperations is excellent in patients with isolated TAPVR without pre-op pulmonary venous obstruction. So those with obstruction, they tend to complicate more than those without. And then that's irrespective of the type of the anomalous connection. So in contrast, survival of patients with TAPVR and single ventricle physiology is among the poorest of all congenital heart defects. Reoperations for pulmonary venous obstruction are rare and are predominantly required in patients who were operated on as neonates. Survival may be improved by using strategy of low-flow cardiopulmonary bypass. And here's another study as well where they looked at the early and long-term results after corrective surgery. And this concluded that despite a possible hectic initial post-operative course of surgery for TAPVR, only a limited number of reoperations is necessary relatively short after initial surgery. And the long-term perspective for those surviving surgical treatment is also quite good. So that was us, and these are our references. And if there's any questions.
Thank you very much. That was a wonderful presentation. There's a lot of positive comments in the chat as well. Please be sure to check the chat for those complimentary comments. Does anyone have any questions that they would like to ask? So it doesn't look like, other than the lots and lots of positive comments, it doesn't look like there's any specific questions. People really loved the images. Thank you for that.
Thank you.
Yeah, and this actually concludes our day, does it not? Let's just have a look here. Yes, this concludes our day today of wonderful presentations. Cecilia and I will be sending everyone some feedback. Recall that there is no grade attached to this assignment, but everyone loves feedback. And so you've all worked so hard, put a lot of effort and thought and time into these presentations. So we'll be sure to make sure that we send you feedback in the next couple of days. So well done, everyone, and thank you to everyone. And Cecilia, is there anything that you wanted to add? Okay, Cecilia may have been called away or may have stepped away. Everyone have a lovely weekend. And we will see you next week.